Aloha and welcome to a unique presentation on pain control with Dr. Linda Dixon. In this video, Dr. Dixon will discuss a wide range of topics from historical and technical information to the practical aspects of applying and using topical anesthetics safely and effectively. I'll be checking in with you periodically just to see how you're doing, but now, here's Dr. Dixon.
Good morning, I'm Dr. Linda Dixon, and I'm here today to talk to you about a very important subject and one that is near and dear to my heart. That is pain control in permanent cosmetics. Our customers have two questions when they are considering whether to wake up with makeup, and the most two common questions are, how much does it cost and does it hurt? So if you can't answer those two questions, you are going to be the Maytag repairman. So when I went into Skin Deep Tattoo Parlor in 1979, I wanted to get my eyeliner tattooed on. It was a tattoo parlor. They'd never heard of such a thing and said, we've never heard of such a thing. And I said, well, that's okay. You can tattoo a line, can't you? And then they said, well, yes, but it's going to hurt. And I said, I'll be still. And so I sat there while they did their first eyeliner tattoo with a coil machine. And I sat there cold turkey and had my eyeliner done. 3 days later, the swelling went down enough in my eyes to be able to open them. And I thought, you know, if I could control the pain for this type of procedure, maybe other people would enjoy permanent makeup too. Remember, this is in 1979, so very little permanent makeup had been done before that time, although some had been, especially with the Japanese geisha girls in the 1950s in Japan. But it was still relatively unheard of. And for a good reason, it was very painful. So that is why I have such a passion for pain control. Not only was I a young mother with 6 children, not only was I a young physician, an anesthesiologist, and this fell right in my specialty because pain control was my passion. I remember when I was 3 years old, I used to stand beside my father's dental chair. He was a dentist, and a very good dentist at that. And I would hold his patients' hands while he injected the local anesthetic, and they would look down at me and pat me on the head and say, "Oh, little girl, thank you so much. That really helped." So I was hooked on pain control at a very young age.
So are you ready to get into the real meat of pain control? First, Dr. Dixon will talk about the physiological effects of topical anesthetics.
Now, what happens to our bodies when we're in pain? We're going to go over the important aspects of safe and effective pain control for our profession. Why? Because pain control is vital for the performance of our profession. And therefore, we should know how to control pain. Well, first of all, our heart rate increases, our blood pressure increases, and we also will have increased swelling and delayed healing. Let's talk a little bit about the history of your client. You should know if they are allergic to any topical anesthetics. What I ask them is, when you go to your dentist, do you have any problems getting numb? And if they say, yes, it takes 3 shots, then I listen to that, because that means they may be more sensitive to pain than, say, another client would be. Have you noticed that some of your clients are really difficult to control pain? And part of the answer to that may be available in the history that we take. So if we take a history and we say, you know, how many days a week do you have more than 2 or 3 drinks a night? So people who drink alcohol excessively or even moderately can have a resistance to pain control. Also, patients who seem to be on mood altering drugs such as antidepressants, Prozac, Zoloft, they tend to be a little more sensitive to pain. I don't know if thyroid really affects it, except that people with not enough thyroid have pretty thick skin, and so they possibly could not be as sensitive to the effects of our topical anesthetics. Clients who are on pain pills or abuse drugs, it's more difficult to control pain in them. I wouldn't say all the time. I wouldn't say they all need more pain control, but I have noticed that some people who do take tranquilizers and pain pills often are dependent on them and will have medicated themselves when they come in. I do not give them any of that medication. Just remember, there are many reasons our clients may find the procedure uncomfortable, and that is because we're stretching the skin, we're pressing down, especially on the eye where we work. The machines, fortunately, we don't use coil machines anymore that are so noisy and scare people to death and sound like a machine gun. We have nice digital machines and quiet rotary machines. This is very important as a method of pain control and permanent makeup. I'm not saying that you can't use a coil machine or you can't use a more silent form of a coil machine. On the contrary, I'm just saying that those can contribute to pain. Clients have a burning sensation. That's oftentimes from the preservatives, especially in the gels and the liquids. One thing that medical studies have learned, especially when they were doing needle biopsies in women's, is that the repetition of a painful stimulus, if you just keep doing it and don't let up, that gets intolerable. So get off, start dotting, start tapping, rather than just moving constantly. Just let off, and if patients are uncomfortable, you can, help them that way. Also, the larger the needle size, the more pain they're going to have. So at least above a size 25 gauge needle, and we do use bigger than 25 gauge needles for most of our procedures. If you stick yourself with a pin, you're going to get what we call a wheal and a flare. So that means you're going to get a red spot followed by a white swollen spot. The wheal, W-H-E-A-L, is from a histamine reaction which causes more fluid or swelling to come into the skin. So it is true that topical anesthetics are not as effective once the skin is swollen, because the fluid in the tissues prevents the absorption of topical anesthetics. And so that's why you shouldn't just keep making passes. Just try to get in 70% of your color on your first pass, and get on your tag gel or your ultra duration or whatever you're going to use, and control that pain and swelling right away.
Pain control is an absolute necessity in permanent makeup. It not only keeps your procedure as painless as possible, but it also helps your clients stay calm and relaxed. After all, there's nothing worse than working on a moving target.
I think it's pretty obvious why pain control is vital for the successful practice of permanent cosmetics, because people don't like pain. And people tell other people if they've had a painful experience. It's vital because we're under less stress too. Not only will our clients be under less stress, we're under less stress. The procedure's going to go more smoothly. We're going to have a higher success rate. Clients are going to tell their friends, their pain was tolerable, and you'll just have a more successful practice. If your client is having pain, it's not just them who is under stress, it's you're under stress. So take the stress off of both of you and stay ahead of the pain. If that means stopping for 2 or 3 minutes while the tag gel works or the local anesthetic works, fine. Just stop and then start again and let them relax. We pay a big price if we don't control pain for our clients. We're working in a location such as the eyes, the lips, even the eyebrows, that are really very delicate, and you do not want a moving target. So the price that we pay for not having good control is that if the client moves or jumps from pain, then we can put pigment. It can be misplaced into a place we just don't want it. So we have what's called an oops because the patient moves because they have pain. So that's the big price. The client can bleed excessively. That also, you also want to know what medications they're on if they bleed excessively, and you also want to back your needle off if they bleed excessively. But obviously if their blood pressure goes up, their heart rate goes up, then up will go the bleeding and the swelling. You'll actually be doing your practice a harm. My dad was a dentist, and one reason people loved my dad, Dr. Harsh, so much was because he was known as a painless dentist. Besides his beautiful dental work, people trusted him and they knew that they would not have pain. Now that's not true in permanent makeup with topicals. They are going to have some discomfort, but I won't ever use the word pain. I'll just say, are you okay? Is that a little uncomfortable? Don't say, am I hurting you? Is that painful? Don't do that. That puts it in their head, and so I never use the word pain. And I'll say, are you uncomfortable? Yes. Well, how many fingers? 1 finger, 2 fingers, 3 fingers? And I say, if it's 5 fingers, hold up all 5, but if it's only 1, and sometimes they'll just keep their fist closed because they're not having any pain. So that's your 5-finger pain test right there.
So how are you doing? I hope you've picked up on how important pain control is in permanent makeup and how critical it is for technicians to be observant and aware during each and every procedure. Now let's hear a little about topical anesthetics used for eyeliner.
Review the ideal topical anesthetic to numb an eyelid before we do eyeliner or eyeshadow or designer eyeshadow or highlighting is close to the eye's pH of 7.5. An eyeliner topical anesthetic shouldn't melt and run into the eye. It should work in 20 minutes, 10 or 15, 20 minutes, and it should last at least 20 to 30 minutes and let you get working until the skin is broken when you can apply TAG gel. It's true, alkaline topical anesthetics can cause corneal burns. It's also true that EMLA, which is a prescription topical anesthetic, is very alkaline. So you never want to use any pharmacy compounded topicals or EMLA around your eye. The safest topical anesthetic for use around your eye would have a pH the same as tears. That's microcaine. That is very safe for use around the eyes. It's got the same pH as human tears, so it's got the same pH as our eyes. Okay, so topical anesthetics make your cornea more permeable, and that's fine if you want to put in antibiotics, but we don't need topical anesthetics in the eye. It's not helpful for our profession, and we certainly don't need any shots around the eye. And but that's all they had for a long time. And but the bruising and the swelling and the pain just from getting shots around the eye is not desirable. Not only that, when you inject local anesthetic into the skin of the eyelids, it causes swelling, and that's right where we want to put our color. So we don't need shots and do not want shots of local anesthetic around the eye. And certainly, if you're not a doctor, don't practice medicine by doing a shot around the eye. So in essence, the topical anesthetic with a range of 7.5, which is the same as human tears, is unlike
the
traditional
safest
tattoo
topical
artists who
anesthetic.
really didn't
So
care
another
whether they had
precaution
pain
is
control
for
their
patients
clients,
with
and many
dry
of them
eyes.
still do not.
Keep bright lights out of their eyes. You can use a drop of eye wash if you need to. Have the client use artificial tears after their procedure and work as much as possible with the eyelids closed. Now, isn't this strange that patients with dry eyes actually can have excessive tearing? So when people call me and they say, oh my goodness, my client had so many tears, I said, did they have dry eyes? And that's something that ophthalmologists are familiar with.
So if they have excessive tearing, actually, it helps to put in eye drops, and then they won't tear so excessively. Now, something that is very important for you to know is the use of occlusive dressings over topical anesthetics. Now, you should never use an occlusive dressing over a topical anesthetic on the eyelid, and it's very simple why. Because if you put an occlusive dressing over your eye, over the topical anesthetic, it's just going to gain heat. And then when heat occurs, there's melting of the topical anesthetic. There's increased absorption into the bloodstream, not necessarily where we need it. It goes clear into the bloodstream. And when it melts and goes into the eye, then it could, you could get excessive swelling, and you could also, get topical anesthetics in your eye, which is not where they're supposed to be. They remain on the skin. So just remember, excessive heat is produced from an occlusive dressing. You don't want that. And excessive swelling of the eyelids. And really importantly, you can't observe the client's eyes. And you want to know if they're opening their eyes while they're waiting there 15 minutes or 20 minutes for the anesthetic to work.
There are specific actions you should and should not take to ensure the safe use of topical anesthetics. It's not only important to protect your clients, but it's equally important to protect yourself as well. So please, follow Dr. Dixon's advice.
You should not use prescription strength topical anesthetics in permanent makeup, certainly not around the eyes. You may have a friend who's a surgeon, plastic surgeon, dermatologist, who thinks, oh, here, I can get you some of this stuff that I'm using. Unless you're a doctor or a medical profession, you should not be using prescription topical anesthetics in your clients. And I am a physician, and I don't use prescription topical anesthetics in my clients. I use over-the-counter strength. And so we don't want any problems that are totally avoidable. Just don't use prescription topical anesthetics. Don't add them to your pigments either. It doesn't work, it doesn't help, and then you're injecting local anesthetics instead of applying them topically. If you've ever seen a needle go into the skin or even into liquid, it literally injects color, no matter what they say. So your needle doesn't have to be hollow for it to be considered an injection. The human factor is that people don't like shots. They would much rather apply a cream or an ointment or a gel than have a shot. I mean, just giving them a shot is, scares them to death, and what does it do? Increases their blood pressure. Topical anesthetics are painless to apply. It doesn't apply anything, and you can actually gain their trust. The nice thing about topical anesthetics is they don't deposit any fluid into the skin like a shot, as I said earlier. So topical anesthetics are much preferable in permanent makeup than to any other kind of pain control. And that includes lips, too. I mean, people don't need dental blocks to get their lips done anymore. We have very good topical anesthetics that handle their pain very well. Don't use artificial tears before you apply your topical anesthetic, because it just fills up the eyes with liquid. It goes between the eyelashes. So then when we put on our topical anesthetics, we've got all that water there. So it draws the topical anesthetic into the eye. And what else does it do? It dilutes the local anesthetic, so you really never get good pain control. And you think you're trying to protect their eye, but it's more protective to use a topical anesthetic that stays put, like microcaine. It doesn't melt and run into the eye, and it's the same pH as human tears. Now, it's important to you, when you get a local anesthetic, topical anesthetic, that it has the proper label on it, so you know the ingredients and you know what it's for. Now, if you get a topical anesthetic for minor cuts, scrapes, insect bites, burns, hemorrhoids, whatever, those are FDA approved uses for that topical anesthetic. Now, so any local anesthetics, if you're not a physician, you're using for permanent makeup, that's off-label use. That's It's ironic that no pigments and no pain control are FDA approved for permanent makeup. Now in 1993, the FDA was writing about permanent eyeliner, and they specifically said that pain control product was used for about 20 minutes before the procedure. So the FDA recognizes that pain control is needed for our procedures, but to date nothing specific. So that's why Unit Dose has tried so hard to make topical anesthetics that are safe and effective and over-the-counter strength. But the FDA and the manufacturer assumes that you know what you're doing when you use the pigments or when you use the topical anesthetic, or you shouldn't be using them, period.
Wow, that was a lot of extremely important information. The great thing about having this DVD is that if there was something you missed or information you'd like to hear again, you can always go back to that spot. Well, now that Dr. Dixon has covered some of the weightier aspects of pain control, how about a little historical background?
Let's talk about the history of topical anesthetics. It's a fascinating history. We all know who Dr. Sigmund Freud is, and he was trying to get his patients to stop taking heroin, and he discovered cocaine, and so his patients were getting off heroin and they were all becoming cocaine addicts. So he gave a little sample of cocaine to his colleague, Dr. Mueller, and it was raining. And so when Dr. Mueller went outside, he licked the envelope to seal it to protect this powder that Dr. Freud had given to him, and his tongue went numb. And he was amazed because it numbed his tongue. And so the very next day, he had eye surgery and used a little bit of this powder in the eye, and the patient didn't have any pain. So even though Dr. Freud was known for all of his psychoanalysis, and we all know he was a drug addict, but at least we benefited and got cocaine. That was the first one. Cocaine's not benign. We've learned that cocaine can kill you too now, but at least we know that it had local anesthetic properties, and so we started looking for synthetic ones. If on your exam they say, what was the first topical anesthetic, and was it Novocaine, was it lidocaine, was it cocaine, or was it Marcaine? Well, the interesting thing is that the first topical anesthetic, the first local anesthetic, was cocaine. Now, what is the gold standard in local anesthetics? Lidocaine was synthesized in Sweden, and to this day, lidocaine is the gold standard in local anesthetics. The categories of local anesthetics are either amide or ester type of local anesthetics. Remember, cocaine, Novocaine were ester type of local anesthetics. Lidocaine is an amide and metabolized in the liver. In our profession, amide topical anesthetics just have a lot fewer problems.
We all know how important pain control is to our clients and for our own state of mind, but it's imperative that we know all the potential pitfalls for using and possibly overusing topical anesthetics. Let's hear a little about toxicity.
The reason we don't get into trouble with toxicity and permanent makeup is because toxicity results when there's too much local anesthetic entering the bloodstream, meaning you're absorbing more local anesthetic than your body can metabolize. Now, one exception is if your client has really severe liver disease. You're probably not going to be working on them. That's a little more common in alcoholics. But you should know the signs of local anesthetic toxicity, and you should make sure that your clients are not on an empty stomach either, because that could scare you too. If their blood sugar drops, they start getting quivery and shaky. Client has some ringing in their ears and the tongue feels like it's swelling. They may even have a seizure, and worst case, their heart can stop. So all of those things are signs of local anesthetic toxicity.
Using topical anesthetics is a great idea, but waiting for them to work can often slow down the entire procedure. But there are ways to speed their onset without lowering their effectiveness. Here's how.
In our profession, we like to speed the onset and get the anesthetic through the dead skin, so sometimes we'll use a microdermabrasion machine because that takes off the dead skin, and then you can apply your topical anesthetic over that area and it will speed the effect of the topical anesthetic. So if you're an esthetician and you have a microdermabrasion machine, you can try that. Don't underestimate the power of a kind word, a nice, touch your patients, hold their hand, be gentle while you're working, firm but gentle, and soothing music. Some people like to take an antihistamine like Benadryl to sort of slow them down, but if that's the case, don't you give them the Benadryl. If they have their own, they can take it, but they should not be driving a car.
Well, now that you have a firm background in the biophysical, technical, and ethical aspects of pain control, it's time to meet the real stars of the show. Dr. Dixon's vast knowledge of anesthesia, as well as permanent makeup, has placed her in a unique position to have developed safe and effective topical anesthetics that can be used before, during, and after each procedure. So, let's see how they work specifically for eyebrows, eyeliner, and lips.
Unit dose was formed when I was trying to solve the problem of pain control in my patients, and that goes back to 1996. So we literally have hundreds of thousands of cases of safe and effective permanent makeup done where pain control has been available to our profession. A lot of people copy unit dose products, and you'll see them by various people. We just try to focus on doing our best. But I would like to introduce a couple of our products to you which are especially helpful in how I do permanent makeup and how I control pain. Now, brows. Some people are easier to anesthetize on brows than others. In other words, when they have a lot of hair, eyebrow hair, sometimes it's harder to get them numb, at least to begin with. As you can see here, our eyebrow topicals are Numb Quick spray, and that's you buff the skin before, or you can buff the skin before and add microcaine. I've found if I buff and spray or buff and use microcaine, I get pretty equivalent pain control, but I always use numb pot. That's very soothing to them, so I combine my topical anesthetics while I'm working, depending on if I want to stay ahead of the pain, if I want to get pain control before I start, or keep pain control, maintain it as I'm working. You still want to use something with epinephrine, so you're going to use Numb Quick spray or Tag gel after you start the brow. So basically you can buff the brow, and it's your choice of microcaine for 15 or 20 minutes or Numb Quick spray, wait about 8 or 10 minutes. After you're done, just put on some Retain ointment. Retain is designed with eyeliner and brows especially in mind to not only soothe but moisturizer and promote healing. Now, let's go on to lip color. Lip color doesn't have to be a problem anymore. We have 3 topicals we use: Numb Pot, Numb Quick Pink, and Ultra Duration. Now we mix the Numb Quick Pink and the Ultra Duration together. That's our cocktail. But before I start, I have them put on Numb Stick, or I apply Numb Pot for about 15 minutes and then make my quick pass. So I want to make my quick pass. Some people turn down the speed on their machine to, like, if you're working with a digital machine, You can turn it down to 60. Some people retract their needles just a little bit. They just want to break the skin a little. So once you've broken the skin with your quick pass, and you can do it with or without color, then just apply your cocktail of ultra duration and numb quick pink, about 50-50. They don't make a nice even mixture. It's more like a cottage cheese in a liquid mixture. Then, in order to maintain the pain control and also to prevent herpes fever blister outbreaks, we use Liprotec number 7. Liprotec number 7 has a local anesthetic in it, very low concentration of lidocaine. It also has what we call our herpes inhibitor, but the local anesthetic effect can inhibit herpes as well. So the topical anesthetics that I use for eyeliner are both safe and effective. The ones that I use before I start are creams. With a pH of 7.52 is Microcaine, a 5% lidocaine cream that will stay put and will not melt and run into the eyes. The other topical I like for eyeliner before I start is Numbfast green cream, and that will not melt and run into the eyes and is longer lasting. It is 2% tetracaine. Once I break the skin and I've made my first pass on the eyeliner, I then apply tag gel, and I do not use an occlusive dressing on any of these products. As I'm working along, I apply numb pot ointment and tag gel to keep the eyelid soothed and numb. Speaking of bleeding, we have epinephrine that is applied, that is used in our local anesthetics topically. Now the reason is that because it stops the bleeding and the swelling, and it prolongs the anesthetic effect. Now it does that because epinephrine shrinks down the size of the blood vessel, okay? They make it, here's the blood vessel, and it gets smaller and smaller and smaller. And so that helps prolong the pain control because it doesn't absorb more anesthetic, which is a safety feature actually if you think about it. So you're not absorbing too much anesthetic, and yet you're still controlling the pain, and same time you're controlling the swelling and bleeding. So don't believe anyone if they say they're allergic to epinephrine. It's just not possible, because if someone comes up behind you and goes boo, you know, then you're going to be scared. That's epinephrine, your fight and flight, and that's normal. So epinephrine is good, and we are limited what we can put in it by over-the-counter drug quantities that the FDA allows, but it's sufficient for our profession. Don't be alarmed if one of your client's eye pupils are very dilated. This is simply a temporary effect from the epinephrine. Now, Arela pain control is something that is near and dear to my heart. Fortunately, they don't have a lot of pain, especially if they have a lot of scarring. But you're still going to be working on or near normal skin. So in all consideration of your clients with Arela procedures, cancer patients, breast reduction patients, that type of thing, you will want to buff and spray the skin. Now, here's where I do buff and spray, and I'll put over an occlusive dressing, usually a piece of barrier wrap, or I'll buff and spray, and then I'll spray some Numb Quick spray into my cotton pad, put it over the area, nice and wet, and put over your barrier tape. So a barrier tape is like, what, 4 by 6 inches. It's big enough to go over the area where you're usually trying to numb. To maintain the pain control, you still want to use your Numb Quick spray, and you'll use some Numb Pot. You won't spend much longer than 20 minutes on one Arela, and you'll be applying Numb Pot, and then when they go home, send them home with Retain. And they can keep a cotton round on their Arela and maintain their soothing effects. So In closing, I've really enjoyed sharing my passion with you, which is pain control. I'm always working on it. I have for the last 13 years plus in permanent makeup, and I think Unit Dose, we make every effort to have the best possible pain control products for our profession. Controlling pain and swelling during our procedure is so helpful. It's vital. It just prevents pain. It prevents swelling. As I said, it prevents our clients from experiencing pain and telling their friends. So it really helps their stress level, our stress level, and it gives us a good reputation. If you have any questions, do not hesitate to call me. I may be difficult to reach right away, but I'm very good at calling you back. I want to thank Tom Bethune. He's been my partner for over 13 years. Our third partner actually died a few years ago, Dr. Wachak. But we worked as really what we used to call a three-legged stool. And we had one thing in mind, and that was to control pain and let us perform what we do best without worrying about our clients' comfort. So again, our toll-free number, 888-664-9990. And I'm Dr. Linda Dixon. I've enjoyed being your host today for pain control, and I look forward to helping you as much as possible and your clients. Aloha and mahalo.